Firstly, a good morning to everyone, or good afternoon now, depending on which part of the country you're in, and welcome to our webinar on drug and alcohol policy development. My name, as some of you might be aware, is Matthew Holton. I'm the General Manager of Operations at Safework Health. In this session, we will explore an aspect of maintaining healthy and efficient work environments, the development of a comprehensive policy addressing drug and alcohol use in the workplace. So in today's changing work landscape, it is crucial for organisations to address how drug and alcohol use can impact employee safety, well-being and productivity. Whether you are responsible for HR, workplace safety, or leading a business, understanding how to create and implement a policy is essential. So our webinar today aims to provide you with insights, practical guidance and best practices for crafting policies that strike a balance between employee well-being, workplace safety. We will delve into considerations, share potential scenarios, and discuss the industry trends as well as regulatory updates. So a lot of you will already know him, but presenting today is our very own Dr. Phil Tynan, who is our National Chief Toxicologist, who will equip you with the advice, knowledge, and tools to develop a policy on drug and alcohol use that not only complies with regulations, but also fosters a culture of responsibility, trustworthiness, and productivity within your organisations. Now, you'll notice just up on the right-hand side, there's a little the little question tab up there. So throughout the presentation, if you can log your questions through that, whilst Phil is presenting, I'll attempt to log all those questions. We'll try to tackle a majority of those questions at the end of the presentation, and if not, like I said, we'll log all those questions and we'll come back with a Q&A document with all the questions and responses, which we'll send out to all attendees. You'll notice up on the right-hand side there's also a little poll tab. So throughout the presentation, Phil will be running a few poll questions, which again are all de-identified. They're nothing too probing, but might give an interesting insight to some of the questions, which we can discuss again at the end. So we're going to work on building workplaces that are safer, healthier, and more successful. And again, thank you to you all for joining us today. And let's begin shaping the future of your organisation's policy on drugs and alcohol in the workplace. And Dr. Phil, it's over to you.
Hello, everyone. Okay, so this is a drug and alcohol policy development workshop. Matthew's already told you who I am. I think most of you know me anyway. So you've got my consolation to that and commiserations. Today's webinar is going to consist of 6 parts dealing with a discussion of the components of an alcohol and drug program, assessing workplace needs, the formulation of the written policy, and its implementation. And this will be followed by a question and answer session where we'll attempt to answer the questions that you've submitted to us. We're also going to be holding 3 polls, as Matt's already said, throughout the workshop, which you can all contribute to. So let's ask ourselves a question. Why actually have an A&D policy anyway? Well, there are basically 3 reasons. One, there's a fiduciary duty of care, which actually is legislated. 2, having a policy lowers insurance risk, but above all, workplace drug abuse is a serious issue. It's got widespread deleterious impacts. Most people who misuse alcohol, prescription drugs, or illegal drugs are actually employed, surprisingly. The 2013 US National Survey on Drug Use and Health found that 68.9% of illicit drug users aged 18 or over are employed full or part-time. And the subsequent Australian surveys, which included also the National Drug Strategy Household Survey from 2019, found that the same proportions actually hold in Australia, roughly a figure of 71.8%. Most Australian binge drinkers and heavy alcohol users are also employed. In fact, of adult binge drinkers, about 79.3% in Australia are either employed full or part-time, and 76.1% of heavy drinkers are employed. Okay, well, that's interesting, but why does that matter? Well, Bernstein and Mahoney in 1989 and Prone in 1988 conclusively demonstrated that on the job drug use and also use during the day prior for drugs with a long impact time, stuff like the stimulants, methamphetamines, speed, and cocaine, does actually lead to substantially increased numbers of accidents and injuries. And the impact's not restricted to raised accident rates. In 1999, Crone et al., in another paper, showed that substance use can lead to increased absenteeism and lower levels of productivity and employee morale, not only for those with the actual substance use problem, but also for those working alongside them. And this significantly raises worksite stress and impairs worksite cooperation. And of course, remember that substance use behaviors are often beyond an employee's control, especially if they develop a substance use disorder, which means that they're psychologically dependent on it, let alone before they become actually physically addicted. So, obviously, preventing substance misuse in the first place and addressing it when it does occur is critical, not only for workplace health and safety, but also for reducing security risks and other possible negative impacts. So, setting up a workplace drug and alcohol program involves five components. These are the need to assess workplace needs, which includes an appropriately tailored policy with well defined pathways and guidelines, creating a written policy for a drug free workplace, implementing the policy and the actual mechanics of drug testing, providing education and training for employees and additional training for supervisors and other appropriate staff. And finally, setting up or at least getting access to an employee assistance program, an EAP. So, to assess workplace needs with respect to substance abuse, there are five questions you should ask yourself. These questions are: is yours a large organization employing individuals in safety slash security sensitive industries, such as, for example, construction, mining, heavy machinery operation, etc.? Okay, in which case you are required to have a relatively intensive and extensive policy. Secondly, does your organization conduct federally, state, or Commonwealth funded projects? In which case, a fully comprehensive program actually becomes mandatory. You're required to. And at a minimum, such a system must involve a fully written policy, which is explicitly stating what's involved, supervisor training, employee education, which must be formally recorded, and an EAP. Now, the third question is Is your organization in the transportation sector with mandated drug testing requirements under regulations? And fourthly, does your organization operate in a sector with a high prevalence of workplace accidents or near misses? Or has your organization experienced a rise in workplace incidents of falling efficiency? And finally, do you employ a population of workers uh, who basically require prevention education, people for whom this kind of education is critical? Okay, this basically would include complex manufacturing, people working in steel mills, electrical engineering, and many aspects of mining. So, what is the assessment process? What does it involve? Well, basically, assessing the magnitude of the problem is obviously going to be critical to securing a safe, drug free workplace, or at least a minimal drug use workplace. And this actually determines the form of your policy. The assessment doesn't have to be elaborate or costly to be effective, but it's got to be exact. Now, by comparing drug use figures for other peer group companies and local geographical drug use statistics, for example, using the NDSHS, or the National Wastewater Drug Monitoring Program figures, you can get a rough estimate of the likely or potential drug use figures in your workplace. And you use both quantitative and qualitative methods. These techniques can be employed to identify the issues relevant to your particular workplace, as well as help evaluate any remedial action that you've taken. However, it's got to be stressed that quantitative methods are much, much more reliable. In other words, they're a much better guide to policy requirements. But let's go through qualitative first. Qualitative approaches include observation, especially those by workplace supervisors, and secondly, just as importantly, management meeting feedbacks. In fact, by raising the issue of drug and alcohol programs during meetings, not only do you have access to the workers' perception of the size of the problem, and they're going to tell you how big they think it is, they'll also tell you the nature of the risks they perceive. And it also helps workers to understand that drug-free workplaces affect important outcomes in their personal and professional lives, as well as giving you feedback on the practicality of actual and proposed programs, which in the long run act to increase worker support for those programs. Now, this brings us on to the real meat of it, the quantitative assays. Quantitative approaches can rely on either indirect measures or physical measures. The indirect measures are survey questionnaires, administrative data, and statistical analyses. The physical data, this is real world data, include things like actually measuring wastewater drug testing for your site. So let's go through them. Survey questionnaires are of some occasional use, but they're limited by self-censorship because there's often a desire by people not to incriminate themselves. I mean, that's pretty obvious. Established survey tools that you can use include the John Hopkins CAGE substance abuse screening tool, which is quite useful, and the alcohol use disorders identification test kit, so-called AUDIT, audit in other words. Now, actually, a better and more reliable approach is to use actual workplace performance data. And this includes things like absenteeism figures, especially on Mondays, Fridays, and the days immediately preceding and just following holidays. Because many drugs that are used in Australia are used primarily recreationally, and there's a relatively high use of the stimulants during these periods, and they have long impairment impact times, which will carry over. You can also look at comparative healthcare claim costs, including costs associated with paramedical service used by your staff, disciplinary action numbers and cases, accident rates, especially those resulting in injuries from mild to serious or even deaths, which are pretty rare, of course. But just as importantly, it's important to actually look at the far more common near miss events, which in the judgment of a peer worker or a supervisor could have led to an accident. These are often early warning signs, which it's important not to miss. You can rely on inventory loss, including shrinkage, which is attributable to theft or damage, staff turnover, especially for specific kinds of jobs or workers, and workers' compensation costs. Now, all this aside, actually the most robust and cost-effective method to generate an accurate real-time snapshot of workplace drug abuse is to get the actual physical data. Well, it's not really practical to test everyone every day, okay? Obviously, that's not going to work. So the way to do that is to perform a workplace wastewater drug analysis, usually over a complete shift cycle, which may be a week or two, depending on your structure. And this will enable an accurate quantitative assessment of total drug use to be made for your worksite. And this can give you a calculation of the number of standard doses of drug per either 100 or 1,000 people at the site, which gives you a rough estimate of the actual number of likely users that you've got. Now, it's important to note, though, that these studies don't actually replace the need for standard workplace testing, because they only give you an indication as to the overall magnitude of the problem at your work site. You, after all, don't know from workplace wastewater testing who actually are the individuals involved with the drug problem. But once you have such a report, you can then design the type, nature, and frequency of the drug testing regime best suited to your needs. Okay, this brings us up to the written policy. Once you know the size of your policy, write your, the size of your problem, sorry, write your policy. Now, a clearly written policy forms the foundation of your workplace program. Now, at a minimum, it should include the rationale for the policy, such as your organizational goals and compliance with laws and regulations, expectations for compliance, including who, what, when, and where. In other words, the employees, job types, contractors, maybe visitors or volunteers, etc. The assistance options to support employees in following the policy, and of course, consequences for violating the policy. Now, there are 5 reasons for having a written policy. 1, it may be required by law or by your organization's insurance carriers. It also makes legal review of the policy both possible and easy. It's quite simple in this case then to change what you've got. It provides a record of the organization's efforts and a reference record if the policy is challenged either by the unions or in a court of law. And this can offer significant protection for the employer from certain classes of claims, including unfair dismissal claims or workplace harassment claims by supervisors, and also incorrect claims about workplace threats and safeties and the failure of management to address them. You can then demonstrate that you actually do have a policy, which, if it's adequate, is addressing the problem. It obviously also makes it easier to explain to everyone what's involved, and it helps employers and employees to concentrate on important policy information. So when developing a policy, you take 3 things into account: the legal requirements of your workplace laws and regulations that apply, the characteristics of your workplace and your employees, and the values and priorities of your organization. Case in point, for example, would be zero tolerance or harm minimization. If you go for zero tolerance, you have to have a far more extensive and a far more intrusive policy. Okay, so what are the basic elements of an effective policy? There are basically 4. The basic elements, one of the basic elements, is a statement of purpose, and this should, at least in part, incorporate the goals, the definitions, the expectations, and prohibitions incorporated into the policy, consequences and penalties involved in violating the policy, and the description of the appeal mechanism. The other elements of an effective policy or strategy are implementation. In other words, how the policy is associated with the testing regime and how it will be performed, and also dissemination of information to the workers. So the statement of purpose ought to contain the organization's goals for the policy and the definition of substance abuse. It should be formal. It may, this isn't mandatory, but it's best policy practice, basically. It may contain the description of how the policy was developed. In other words, was it developed in meetings with the union representatives or in collaboration with the organization's legal counsel? This can again protect you from certain claims made against you. How extensive your SOP is, again, depends on your intent. SOPs may include explicit statements to the effect that the purpose of the policy is, for example, A, to meet the requirements of applicable laws and regulations and ensure a drug-free or minimum drug use workplace, and or B, to establish restrictions on workplace-related use of illegal substances such as alcohol, cigarettes, legalized marijuana, and prescription drugs, as well as restrictions on illicit substances. So SOPs can also address fitness for duty behaviors and to explain the steps that will be taken to protect employees identify the problems, and bring assistance. And this brings us to the goals of your policy. Questions that you may want to consider in defining your policy goals are: what other goals does your organization expect to achieve? For example, as we've mentioned before, reduction or elimination of drug related workplace accidents, reduction of illnesses and absenteeism, drug free versus simple harm reduction. And as noted, if you really want to go for zero tolerance, absolute drug free, it favors much higher rates of testing and almost invariably requires you to test with urine rather than oral fluid. And I'll go into that in a minute why. The question that should be asked is: does your organization want to address the issue of preventing and treating workplace drug use and misuse in the context of accomplishing a broader goal, like generally promoting worker health and safety? Following this, we then consider the definitions, expectations, and prohibitions. Now, all policies need to specify their definitions, their expectations, and their prohibitions. In practical terms, you need to define substance abuse. You need to state what employee behaviors are expected, what substances and behaviors are prohibited, state who's covered by the policy, for example, employees, contractors, visitors, state when the policy will apply, and this is important. I mean, for example, it might be only during work hours. It might also be during organizational sponsored events after normal business hours. You need to specify where the policy will apply. For example, in the workplace while the worker's on duty, outside the workplace while they're on duty, or in the workplace and in organization owned vehicles while they're off duty. You need to define who is responsible for carrying out and enforcing the policy. Uh, for example, the worker's immediate supervisor or the general site supervisor or your WHS representative. You need to define which drugs will be tested and how they'll be tested. That generally means urine and or oral fluid. In some work cases, they may also resort to hair testing if they require long-term proof of abstinence. This is more common in medical and paramedical services, for example. This will also require a distinction to be made between screening tests and any attendant non-negative, including provisions for dealing with the finding of a non-negative screen, and of course, the confirmatory tests, the laboratory send away tests. You've also got to define and explicitly outline how infractions will be dealt with. In other words, what's the scope of penalties and what worker support and services will be made available for drug using or drug dependent employees. It may also be necessary to determine and formally state if any employees are covered by the terms of a collective bargaining agreement, and if so, how the terms will affect the way the policy will be implemented and enforced for their employees. And finally, of course, consequences and appeals. Addressing the consequences of violating the policy and the procedures for determining whether an employee has violated the policy is crucial. Otherwise, Fair Work can hit you with that because they can claim it as an unfair or so-called occult, in this case, hidden, unexposed, not open, not transparent policy. So your policy should also outline the procedures for appealing a determination that an employee may have violated the policy, potentially also your procedure for seeking a toxicological review. For example, we make it a sample and you ask, for example, me, is this result consistent with the person following their prescription? They may be on codeine, for example, and you want to know, is what we've found consistent with it, or are they taking extra? And thirdly, of course, you need to have a mechanism described for a donor requesting the test by a third party laboratory if they're challenging the result. And this is, of course, performed on the so called B sample, the second confirmatory sample. Okay, so this brings us up to having the polls. And Ideally, as you all know, you should review your policy every 2 years. So let's have a poll. How often do you perform? Let's see, sorry, it should be on. Yes. How often do your employees get drug tested every year? Is it less than once a year, twice a year, or rather unlikely, more than 2 times a year? We'll discuss the findings of these. Matt will collate them, and we'll see how everyone basically compares. And I'll tell you what the industry figures are that we have available. Okay, now this brings us to implementation. Question that arises, of course, is what drugs are being tested? Well, the drugs that will be tested, that must be tested, include those in the Australian standards, which include AS 4308 2008 and its successor standards. In fact, the new standards, the 2023 standard has come out, the procedures for specimen collection and the detection and quantifications of drugs of abuse in urine. This actually won't be enforced until another 36 months have passed, but there will be some changes, and it might be a topic for one of our future webinars to discuss what you should look forward to over the next few years. Alternatively, you might be using oral fluid testing, which brings you to the AS 4760 2019 procedure for the specimen collection and detection and quantitation of drugs in oral fluid. And of course, the AS 3547 2019 with alcohol testing devices. So your basic testing will include breath alcohol. In other words, essentially a breathalyzer function. Your DNA policy must decide whether to adopt a zero tolerance, in other words, a BAL of 0.000, or a 0.01 or a 0.02 intervention threshold. And if alternatively variable thresholds depending on what the task of the worker is. And you've also got to define the waiting period of the secondary, as they say, the post-initial reading test. In other words, once you've got a breath alcohol reading, you should redo it again 20 to 30 minutes later. And the reason for this, there are two reasons. One is to exclude what's called mouth alcohol. And this is where you get a factitious and short-lived rise in alcohol reading from reflux or gum disease. It doesn't mean you're taking any alcohol, it just simply means you've got fermentation in your gut and you've been belching. Or you've got gum disease and bacteria and maybe gobbling the sugars that you've just taken. You may have had a cupcake or something earlier on the day. It's also to compensate for the possibility that the donor might be in what's called the absorptive phase. In other words, they may have taken alcohol within 2 hours of testing. You really want to know how badly affected they really are. One piece of advice, in general, urine alcohol should not be used because the detection window is much longer than the impairment window, a little bit like THC in urine versus THC in oral fluid. Urine alcohol is useful, but only demonstrates alcohol has been consumed in the past, say 12 to 24, sometimes up to 36 hours. It doesn't correlate well with the donor's current state. There's a lag phase of roughly about 3+ hours. In other words, your urine result will say what they were like 3 hours ago, not now, and that's a problem. Okay, let's get to general drug screening. These will include the amphetamine type stimulants, ATS as we call them, which includes amphetamine, in other words, speed, but also dexamphetamine, which is prescribed. It includes methamphetamine or ice, which we don't prescribe, ecstasy, in other words, MDMA, and MDA. It'll include classical sleeping pills like benzodiazepines, cannabis, cocaine, standard opiates like morphine and codeine, as well as heroin, of course, and the newer semi-synthetic opioids like oxycodone and to an extent fentanyl. Oxycodone's already in the oral fluid standard, and it actually is an optional drug in the new urine standard, which will be introduced over the next few years. But again, as stated, it's optional, not mandatory. Now, as noted above, provision should be made in the procedure for dealing with things like non-negative screens, specifically those workers awaiting the outcome of laboratory confirmatory tests. So consider the case of a worker taking a prescribed drug that's known to cause false positive cross reactions in screening. Let's say Joe Bloggs has got ulcers and he's taking a proton pump inhibitor. And you find out and say, geez, mate, you've been taking amphetamines. And he says, no, I haven't. Well, if you use a cross reaction list, for example, that may help you in these cases. And if you have an established policy for addressing what to do in these cases, that basically frees you from having to reinvent the wheel each time the issue comes up. You may decide to err on the side of caution and say it doesn't matter, we'll still basically hold you until we get the confirmatory test result. Or you'll say, look, we've looked at you, we've looked at an impairment checklist, you don't appear to be impaired, and we know from a formal cross reaction list that it can cross react. And we've got evidence you actually are taking the drug. You could provide the prescription, evidence of it. And so therefore, we've had this with you before, so you therefore may decide to allow them to still stay at the workplace. That's really up to you. This brings us to confirmatory testing. Confirmatory testing should cover all the standard listed drugs. Can also, by the way, be extended on your request to other drugs of interest, which of course would include fentanyl and ketamine, as well as other drugs of abuse where it's deemed appropriate. Just as an aside, the National Wastewater Drug Monitoring Program, which is just across Australia, has now added ketamine to their list because we have a problem with ketamine. Ketamine use throughout Australia is increasing monotonically every year for the last 3 years or so. So this then brings us on to the question of what type of sample. The fundamental choice is obviously between urine and oral fluid. So a decision should be made as to what media is preferentially used, and you've got to factor in the advantages and disadvantages of both media. Now, in general, with the exception of cannabis use, urine is a superior medium for screening. The big problem is it's not convenient. It requires special collection sites, toilets in other words, and it's way more intrusive and you have to wait a lot longer. In terms of convenience and having a detection window, which actually correlates with the impairment window of cannabis, in other words, THC, oral fluid's clearly better in that case. Remember that the impairment window from cannabis, it's real, it is significant. It'll persist on average 12 to 16 hours. It'll be quite serious for the first 8 to 10 hours, depending on dosage. Whereas, of course, urine THC detection window is about 3 to 5 days and can even extend up to 5 weeks. It's dependent on obesity and frequency of use, and it doesn't correlate with impairment as well. Now, some work sites do urine screens, but they'll do an extra oral fluid screen only for non-negative urine THC screens. And what they then do is they take a oral fluid sample, they screen it, and if it's negative for THC, they formally report the result as negative because they don't care that you were using it on the weekend. They care, are you impaired now? And the take-home message with oral fluid, just for THC, if it's not detected, they're not affected. However, there's a problem with oral fluid and the amphetamine type stimulants. I'll get to that in a minute. Now, there's no advantage or disadvantage between urine and oral fluid for your ordinary opiates, none at all. That brings us on to the inadequate detection window for the ATS, the amphetamine type stimulants, for oral fluid. And this is especially so for amphetamine and methamphetamine. ATS impairment lasts about 72 hours for amphetamine, up to about 96 hours for meth. But the oral fluid detection window for these drugs is about 24 hours, rarely ever exceeds 36 hours. Trouble is, ATS associated accidents peak after 18 to 24 hours, usually around 36 to 48 hours post use. We think what may be happening is these people are having microsleeps. And even worse, oral fluids fail to detect benzodiazepines well. And this is not a problem with the technology. Benzos are only weakly excreted in saliva. And unfortunately, benzos are the preeminent, commonly prescribed drug class that is the leading cause of prescription drug associated workplace accidents. Just excuse me while I have a quick drink. Don't worry, guys, it's Diet Coke. Okay, so that brings us up onto what type of medium you choose. Well, the important thing is what medium you choose will be determined by the occasion for testing. In other words, the type of testing. These include 6 basic occasions. These will be pre-employment testing, and in this case, urine is generally favored as it has a much longer window of detection, and you really want to exclude someone who's a drug user early on. This also involves random testing at work. Now, if possible, you might want to use urine, but oral fluid is often used because it's a lot quicker and it's a lot easier to do. Thirdly, blanket testing. For convenience, as large numbers would be tested in such a case, oral fluid testing is more often used in these circumstances. That brings you on to focus testing. That's where you've got an area where you know there's a problem, there's an established record of drug use, and you are concerned. In that case, it's probably better to use urine because it's got the best overall detection rate. It's also got a slightly lower false positive rate, by the way, so you won't have to call the worker and put them down until you get the laboratory confirmation result as frequently if you rely on oral fluid on urine as the higher level you'll get if you relied on oral fluid. That brings you to 5, which is post-incident or on suspicion testing. Now, in this case, urine is strongly recommended for this purpose because there's a limited detection window for oral fluid. We've stated already there's poor recovery of benzos, and in fact, even recovery of cocaine is pH dependent. You can actually take a couple of lines of nose candy and then acidify your saliva, and it won't be detected because it literally won't be excreted in the oral fluid for a period of about an hour or so. That's a trick quite a few people do. Now, when testing on suspicion, it's often helpful to have something like the UCLA impairment checklist to both document why the worker was targeted, in other words, create a formal record you can reference later, and also as protection against harassment claims. And so industry best practice, they often include these in their policies. And finally, of course, we have abstinence testing and rehab, in which case urine is by far the best method. It's also very good in this case for THC because there's an algorithm for testing THC reuse. And this brings us back to another poll. And okay, let's see what's happening here. Why have we got the old one? Let me just see if I exit the old poll and start the new one. Okay. No, okay, add a new poll. Just a moment. No, that's not doing it. Matt, do you have any idea?
Now it should activate, Phil.
It should.
What did you do? What did you do with the first one?
Nothing. It's just there. Should I turn? I'll turn the. I'll make the poll inactive. I'll start again.
Yep, and start it again.
Okay. No, that's that one. Okay, let's just see if it's maybe higher up. Okay, this one. Sorry. Apologies, everyone. Okay, this brings us on to the type of sample we base our AOD tests on. Is it oral fluid that you use, urine, or does it depend on the context? It just, oh, okay. It's interesting to see what everyone's saying. Nice to discuss that later on. Okay, well, that brings us up to optimum testing frequency. How often should we test? Well, this is an area which has been poorly explored actually in the literature. The optimum testing frequency requires a balancing of testing costs with the saving accrued by accident prevention, and it's going to vary with occupation. The major papers include Marquez et al. In 2014 and the HR 993 2017 report from the European Union. Sorry about that, but that's literally how it's named. And Marquez, for example, reported that for train driving, the optimal testing rate is up to but less than 3.5 times per worker per year. In other words, if you test more often than that, you get no advantage at all. However, for most workers, including most miners, and those in most safety critical occupations, which include mineral extraction, heavy machine handling, materials processing, heavy transport, electrical engineering, water management, as well as decision makers in authorities over the areas, construction engineers, and high ranking white collar workers and professionals, the optimum testing range is between 1 to 2 times per worker per year, certainly above 0.5. And there's actually a marked improvement for all these categories, normally seen around the rates between one test per worker per year to 1.5 tests per worker per year. The improvements you get after that are incremental, but the major improvement occurs when the workers know they'll be tested at least once a year. Now, by aggregating the various study findings and applying which apply the optimal random drug testing strategies in various industries, they found that it leads to a 59% accident rate drop for workers on board trains and safety critical sites and other safety critical occupations. And in other words, that's testing between 1 to 1.5 times per year for those workers, and 72% decrease for those working in moderate risk sites. And interestingly, an 85% drop in white collar mistakes, not accidents per se. So testing at the optimal frequency generates net savings of at least an order of magnitude in most personnel. Now, collating the available papers, which I've done, the evidence is across the board in the OECD that the goal is to achieve a testing rate in all industries of significance between 1 to 1.5 tests per year, except for those which are purely white collar based and with minimal safety risk, in which case it's between 0.5 to 1 tests per worker per year. If you get between 1 to 1.5 tests per worker per year across all industries, it's predicted you'll have a reduction of 40 to 50% in overall worksite accident rates. One thing to note, though, above all, it's actually the perception by your workers and by drug users among them that they will be caught that is critical. If they believe they can be caught because they're being randomly selected, that's when they'll actually control their drug use. So this brings us to a new poll. Just bear with me while we get up there. Okay, basically, have you reviewed your drug and alcohol policies in the last 2 years? Because ideally, they should be done. Okay, um, that's an important issue. Now, a question to ask though is who's doing the testing? At a minimum, workplace drug testing must be compliant with the relevant Australian standards, and you've got to actually note that in your policy. And this requires training of collectors who must achieve proficiency in the task and be familiar with the requirements for a fully compliant collection that's medico-legally secure. In other words, you've got to make sure that your people actually are accredited. Any external drug testing agency will obviously do that, but if you're using your own people, they actually have to be properly trained, and it has to be accredited that they actually are competent in that area. Okay, so that brings us up to education. Education in the workplace about AOD policy is critical. Employees will be better able to cooperate in improving the workplace if they're brought into the process early. It helps employee acceptance if the expected benefits of the program are explained to them. In other words, reduction workplace accidents and near miss, reduction absenteeism rates, improved safety for all workers, a less stressful work environment, and ensuring that there is available support for drug use and drug dependence. And this enables them to see that it is fair and it is in their own best interests. And of course, be aware that educational programs are available that cover the basic concepts, the benefits, and the issues involved in implementing drug testing, and that programs can be tailored for specific groups, for example, managers or supervisors, or for the general consumption of the employees. And so this brings us to employee assistance programs. Now, these help employees by connecting them with confidential access to treatment and helping them find providers who will provide support to maintain a drug free, drug abstinent state in people who are already drug dependent, and also help them to recognize the actual potential triggers and inducers of a relapse and what strategies they should be employed to prevent relapsing. Note also that EAPs may be called on to manage the recovery and return to work process for employees who test positive for misused prescription drugs as well. So a DNA policy must outline explicitly all this information. It also has to include a pathway by which a compliant employee may return to work and those conditions under which a return to work cannot be permitted. So let's wrap up. It's important to emphasize the six core principles. Assess your workplace and its needs related to substance use. One of the best tools is wastewater drug testing to give real time snapshots of your actual drug levels. Secondly, develop a written policy for establishing a drug free or minimum drug use workplace. Thirdly, determine how to perform drug testing at your work sites and what sample or combination of samples best suits your needs. Fourthly, provide education and training for your employees, and you actually are mandated to do this, and appropriate training for supervisors and other appropriate staff, as well as ensuring collections are done appropriately and compliant to standard. If they're not compliant, they can easily be challenged in court and tossed out. Fifthly, set up or have access to an employee assistance program. And finally, of course, always reassess your policy at regular intervals and adapt as the circumstances require. Okay, so that brings us up to your questions, everyone.
Okay, Phil, hold on. It's nice and straightforward at the moment. Do you want to quickly have a to see if any more questions come in? Do you want to just quickly go through the poll responses and if you got any comments on that? Phil?
Okay, let's have a look at the poll responses. All right. Basically, everyone, the majority of people have reviewed their drug and alcohol policies in the last 2 years. 81%. That's interesting. The Australian industry average for workplace safety critical places is about 78%. The Australian general industry average is an unfortunate 70%. So, guys, you're a rather exceptional bunch. Congratulations there. Now, let's have a look at your other ones. Let's have a look at this one. Okay. What type of samples are people basing their tests on? 22% exclusively for oral fluid, 16.67% for urine. Those who have a mixed policy, it depends on the circumstances, are slightly over half, 53% in fact, and 5.26% say it's not applicable. Okay, so I'm not entirely certain how you run your drug testing system if no one's doing any. Okay, the figures have changed. Sorry, guys. It's now 30% oral fluid, 20% urine, 45% depends on context, and 5% non-applicable. Interestingly enough, uh, most workplaces in Australia, according to the industrial figures, about 54% use a mixture of urine and oral fluid, depending on context. Overwhelmingly, most people will use urine if it's on suspicion or post incident. They'll also use urine for pre employment testing and also on fitness to return to work. Um, as for the other categories, uh, the majority, well, it's complex. The majority use a mixed system. You have roughly about a third, rather similar to what we've got here, using oral fluid. You have between a fifth to a quarter will use urine. These are using them only, and the remainder of the mix will actually generally use urine in most cases, relying on oral fluid when they've got a positive THC. The only time they generally rely on oral fluid is when they've got to do blanket testing with large numbers of people, because there's an issue about how long it would take to actually run testing if it was all blanket testing done using urine. Okay, that then brings us to the final poll. Just bear with me. And let's get to that one. How often do your employees get tested per year? Less than once per year. It's about 61.9%. Once per year is almost a fifth at 19%. Twice a year, it's almost a 20th. I'm impressed with the more than twice a year. Um, be interesting to have a discussion with those who do more than twice a year to see how often you actually do the testing. As I said, saturation appears to kick in at least, according to Marquez, around about 3.5 times per worker per year. But it'll be interesting to see what your feelings are about that, and whether you feel it's effective doing it more frequently. As for those who do it less than once per year, my suggestion is as well, industry best practice across the board has the level of testing at least once per worker per year, less than once per worker per year, unless it's a purely white collar profession and also not involving clerical activity with a significant financial or health impact. In which case, it's got to be above zero point 0.5, but maybe up to or less than once per year.
Not a problem.
Okay.
Thanks, Phil. Look, I'll quickly. Not a lot of questions here at this stage, and again, you can follow up at any stage with any further questions. So I'll quickly run through these for you, Phil. Performing the testing of wastewater, is that something you are able to carry out on all sites? Is it an easy test to complete?
Yes, most sites. It's a pretty. Everyone has to go to. I mean, you've got to have somewhere where they go to the toilet, and it's only in rare cases you can't do it. Um, in most cases, it ought to be sampleable, and there are ways to get around issues such as, for example, you may not know the flow rate, in which case we can simply, so long as you give us accurate worker figures, we could then assume that every worker passes the average number of motions, and the flush volume is the average flush volume for toilets in Australia. And we actually do have figures for that, which have been provided, interestingly enough. So yeah, you can get by even when it's not a very complex or very intensive water handling facility.
Yeah, and look, just to build on that, Phil, the process is generally we'll come out and visit the site. We'll have a look at the wastewater management system. We'll look at the different catchment points before hopefully it gets to any form of treatment, and we can generally and look at the availability of taking the samples, which generally is not too difficult. And we can break down that further. Yeah, for example, you've got a workshop and then an administration. If you've got two different catchment points there, we can take two lots of samples, and it gives you it allows you to break down those two populations as well. So,
The great advantage, if I may say, Matt, with wastewater testing is you can then test in real time is your drug intervention strategy working?
Yes.
In other words, you may have given everyone the motherhood lecture, and just think of our boys on the Malabar front. Think of what they have to put up with. Don't take drugs. Do a Nancy Reagan, just say no, and then you want to test it again, usually after 3 months or so, and that can tell you, is there a statistically significant difference in drug use, or does it remain pretty much the same? It also tells you which subgroups among your workers, which shifts, for example, to focus on what days do you more commonly have increased drug use. For example, oxycodone and fentanyl use frequently correlates with the arrival of contractors, especially if you're outside the major cities.
Yep. We'll move on to second question. Can you share the evidence base for more than one test per year, or more than one per year DNA testing programs, reducing accidents by X%,
Yeah,
please?
I'll give us your names and I'll send you stuff on that.
We'll probably add that into the Q&A
Yeah.
document that we send out at the end. Do you see
If
a
you give me,
time?
if you give me about a week or two, I'm actually in the process of basically collating a whole series of documents together to give you figures. Dealing with, it's mostly European data, I must admit, but the latest European data on their recommendations for doing, and they say more than once a year, but they're not going overboard about the numbers.
Yep, not a problem. Do you see a time when we will have standards for hair?
Yes, we already de facto use the Society of Hair Testing Standards. The only reason it hasn't yet been formally standardized is the Europeans. There's a big bun fight between the Germans and the French. The French have a slightly different policy.
Not a problem.
So I would assume in the next 2, 3 years we will.
Next question and final question at this stage. Do the laboratory test results reflect how long ago the worker is likely to have taken THC? Namely, can the result be converted into a rough timeline of when the THC was used? You love these questions, Phil.
Okay, with urine, that's extremely difficult, and the answer is no, unless we know what doses they're supposed to have taken. For example, if you're asking someone who is taking medicinal cannabis, they have a particular script, you have given me their weight and height, the frequency at which you're taking, I can say therefore that the urine result is consistent with this or it is not consistent with it. Or they've used it more frequently. Generally, though, time since usage, if you collate it with an American National Institute of Drug authorities, NIDA, standard cannabis cigarette. And yes, it does exist, Virginia. There is such a thing. They've got a high dose, low dose cigarettes. We can correlate the actual quantitative level in oral fluid to the standard NIDA cannabis cigarette to the standard user. But that's not, it's not horribly accurate. It will give it to you within 4 to 6 hours of most likely use. In other words, this guy either used one standard toke 6 hours ago, or he had two standard tokes more than 12 hours ago.
Not a
Okay.
problem.
The important point being, though, if you've got it in oral fluid, you're affected. One thing to note: the excuse of passive inhalation of oral fluid is rubbish. It's only detectable, barely detectable, even in oral fluid, less than 2 hours after being stuck in a room the size of a Volkswagen, old-fashioned Volkswagen Beetle, which is unventilated. It would be bad enough to give you conjunctivitis. So, no, you can't claim it's I was there where someone was smoking but I didn't inhale.
So, not a Cheech and Chong scenario, Phil.
No, unfortunately for people.
No worries. Is the writing of a new DNA policy or review of an existing policy or service that Safework can provide?
Yes, it is.
In short, yes.
We
Um,
can give you as extensive or as short as you want. We have templates. We can do all that for you quite easily. Usually, you just tell me what the job is, what your workers are, what kind of work you do, and you also we will discuss with you what do you want to test, what kind of samples do you want to use, and this will be determined by what kind of testing you're doing and what the workplace health and safety issues are. If it's making lessons for the school kids, I'm not going to be as stringent as, for example, someone in construction or mining.
Not a problem. Okay, last question, just bearing time now. Last question. Do we need to notify the employees that we are going to conduct wastewater testing?
No, there is no
Simple.
legal requirement to do so, and arguably, there's no ethical requirement to tell them. It's an assumption and a reasonable assumption that you are maintaining a safe workplace. In fact, you have an absolute fiduciary duty of care, and it is held by Australia's High Court that there's no requirement to inform the workers of what you're doing with the wastewater. The only time you'd have to inform them is if you discover that, oh God, we've got Ebola in the wastewater, or we've got toxic levels of mercury, and you have been exposed.
For health
I mean
reasons.
that's a health assessment, health risk for you. But to actually do testing of drug levels, no one needs to be told. And common practice is that you don't, because you don't want people faking it during the time they're testing.
But Phil, would you advise that it's something that potentially could be written into their policy that at any given time the business, the organisation will be conducting wastewater testing?
Yeah, at the discretion of management,
Yep,
wastewater testing can be
when seen
test.
required.
Yeah, and notification is not required, and they can ask for it, but they've got no legal entitlement. This is
Yep,
not intrusive of the workers. This is a review of the workplace,
yep.
not of the actual workers, and so therefore it isn't covered either by the workplace agreements or by Fair Work Australia regulations.
Not a problem. Not a problem. Okay, well, look, that's answered all questions. We've tipped that just over the hour. So, Phil, thank you very much for your presentation. Greatly appreciated. I hope everybody found the information valuable. Like we said, we will be sending out a Q&A and I think, Phil, with that additional information uh,
Absolutely.
that you were looking at sending out, we'll get that out. I think Melanie has made note on there that this presentation will be available as well after the fact, which will be emailed out with a link of the video. But again, just look, thank you for everyone for all their time. And if there are any questions post this presentation, then by all means, feel free to get in contact.